is hypertension, with really the focus of hypertension in older patients. So I have a lot of objectives. I think I can get them all in though. So we want to discuss the prevalence of hypertension in older adults, identify risk of developing hypertension and outcomes related to chronic hypertension, explain the methods to decrease blood pressure, recognize the recommended goal blood pressures in older adults because they can be different and they have been very variable. Identify medications that aggravate hypertension. So that's kind of, you've heard me speak before, is I always want to look at when we have a new symptom, is there a medication that could be contributing? Then I talk about antihypertensives with risk in older patients and finish up with a couple of cases. All right. So first of all, the prevalence of hypertension, and I'm sure many of you have been exposed to this, is that hypertension risk increases as patients age. So we only have a 27% prevalence in those that are less than 60 years old, but 74% prevalence in those that are greater than 80 years old. And I thought this other little statistic was significant, that 65% of men and 75% of women will basically have hypertension by the age of 70. So a very common thing that goes on with our patients. So why does, I don't know if you're like me, but I kind of wonder, why is hypertension so much more prevalent in our older patients? And there are some physiological things that happen that make our older patients more prone to hypertension. So the arterial stiffening that can occur with age, this is a normal part of aging, that we see this stiffening. And with the stiffening, it just means that the vascular isn't really able to dilate when we get changes in volume. So rather, if you can't, kind of like a garden hose, if you can't make that go larger, if it doesn't have some flexibility in it, then it's going to make the pressure higher. We also see these neurohormonal changes that happen. We do see some endothelial dysfunction, which decreases nitric oxide, and nitric oxide normally is something that would dilate the vessel. So if we're decreasing nitric oxide, we're going to end up with causing some vasoconstriction, which will cause the blood pressure to go up. We do see also a decrease in renin secretion, which can affect sodium, and that also can lead to hypertension. For autonomic wise, we can see a reduction in the baroreflex response. So this is a response that tries to keep your blood pressure about the same. And our older patients, it just does not work as well. So a younger patient may take a medication that causes them to have some orthostasis, but the baroreflex is going to kick in pretty quick, and they might not even feel dizzy, or if they do feel dizzy, it might be for just a minute. But for an older patient, that's going to not work as well, and the patient may actually fall because they have that orthostasis. We also see in our older patients something that is called postprandial hypotension, and this is hypotension that occurs after you eat. How it's been explained to me is that the blood flow goes more to the GI tract, so you end up hypotensive. So ways that we can avoid this is to basically have meals that are smaller, that are more often, to not get up quickly from the table after eating, to allow your body to kind of readjust after digesting the food. So those are two ways to avoid that. We also know that our kidney has some changes, and there's been a lot in the literature lately about maybe we don't need to worry as much about sodium causing blood pressure to go up. That's not true in our older patients, and that's because we do get more of that vasoconstrictive response to high sodium levels as patients age, so much more than in younger patients. So it is still important to keep track of sodium and try to stay within the dietary recommendations for patients with hypertension. We have all kinds, and I'm sure most of you have been familiar with this, is that we have all kinds of really bad outcomes that can occur from having sustained hypertension. So brain-wise, definitely associated with increased risk for stroke. It's also increased risk for vascular dementia as well as Alzheimer's dementia. For the heart, we know that high blood pressures can contribute to the development of atrial fibrillation, heart failure, and also heart attacks. Kidney-wise, we know high blood pressures can contribute to chronic kidney disease, and then also for the eyes, retinal disease as well. So maybe somebody can unmute and tell me what is the most common hypertension symptom for most patients. Anybody have any ideas? All right, I don't see any takers. So I will let you know that there are no symptoms, and that is really for most people with hypertension. Until your hypertension is very severe, you're not going to have symptoms from hypertension. And you may have heard it called the silent killer because it doesn't have symptoms, that it can creep up on people, especially people who are not good about keeping their appointments and going to the doctor on a regular basis. So very important that we advocate for patients to definitely keep track and make sure that they don't have hypertension. And thank you, Michelle. Yes, it was kind of a trick question. Sorry. I will say that was in the chat. And I will say, though, the other thing, whoops, we went a little bit too far. That when blood pressures are high, there are some symptoms. So a headache, nosebleed, and blurred vision are the most common symptoms when patients have very severe hypertension. All right, next we want to talk about we're going to delay our talk about prevention of hypertension. There are ways to prevent hypertension. They're the same as the non-pharmacological treatments for hypertension. So we will talk about that in just a minute. So I want to talk a little bit about gold blood pressures in older adults. And thank you for dizziness. Somebody put in there as a symptom of hypertension, and I agree, especially when it is more severe. So gold blood pressures in older adults has been a very controversial subject. Let's see if I can get the slide to move. There we go. So I just have a question, and you don't necessarily have to answer it. We're going to answer it in a few minutes, but you can see, and I'll give you the background, why there are so many different organizations that have weighed in on these 2017 guidelines for hypertension. So the question is, what is the blood pressure goal in an 81-year-old female who has a history of hypertension, osteoarthritis, an MI, CVA, congestive heart failure, and preserved ejection fraction? She has fallen in the last months, and she resides in assisted living. And I think we skipped a slide because this is a very similar patient, but her history is just hypertension and osteoarthritis. She reports no falls in the last 5 days, and she exercises regularly. She swims 5 days a week and walks a mile a day. So two patients, same age, different history, and different types of activities that they are doing. So when we talk about hypertension goals, I am going to quote just a couple trials here that are kind of classic trials. There are quite a few others, but I wanted to kind of let you know about kind of the landmark trials that have changed the way that we practice. So the first one is the HIVET trial. The HIVET trial is an old trial way back from 2008. And it's a randomized double-blind placebo-controlled trial, had over 3,000 patients. So a good design. It only included patients greater than 80 years old because at the time there was a controversy about whether we should even treat hypertension at all in patients over the age of 80 years old. The systolic blood pressure that they were shooting for was less than 160. It took place mostly in Eastern Europe and Asia. We do apply it to our American patients, but it's just important to know there were American patients, but a lot of the patients was in Eastern Europe and Asia. They gave a very set type of medication, indapamide plus perindopril, which is an ACE inhibitor, versus placebo. And their target blood pressure was less than 150/80. So you had to be greater than 160 to enter the study, but their target blood pressure was less than 150/80. And they were looking at stroke and mortality. And what they found, there was a non-significant reduction in strokes in the group that got the medication. So it was reduction, but not big enough to actually reach significance. But they did have a significant reduction in all-cause mortality in the group that got the medication. So death from any cause had a 21% absolute reduction, so that did meet significance. And they said the number needed to treat to prevent one death was 4.76 patients. So, according to this study, it doesn't help to reduce strokes, but it is helping with other things, so that we did see a decrease in death. And we were treating hypertension after this study in patients that helped to answer that question, that yes, we should be treating it in patients over the age of 80. The SPRINT trial is the next classic trial that came out. I can't believe it's been already 2015, so it's already been quite a few years since this came out, because this also changed practice quite a bit. It took a little while for everybody to implement it. But this was a randomized trial in patients and it was in over 9,000 patients, and 25%, so a quarter of those patients were over the age of 75 years old. So to enter this trial, the patient had to be over 50. They had to have at least one cardiovascular risk factor or renal disease. A big issue with this trial is it excluded patients with diabetes, with stroke, or if they had heart failure with an ejection fraction less than 35%. So excluded a lot of patients that, older patients that have these types of things are very common. They also excluded patients with orthostasis, on many medications, which I believe they were referring to hypertension medications, and having systolic blood pressures that were greater than 180. So the issues with this study is really it excluded quite a few people. But what they did find at 3.26 years, they had a composite outcome was significantly decreased. And that composite outcome is they looked at patients that had MI, if they had acute coronary syndrome, stroke, heart failure, or death from any cardiovascular event. So we did see a significant decrease in that. We saw a 38% decrease in heart failure, 30% reduction in cardiovascular events, and 43% reduction in death from a cardiovascular event. And I don't have it memorized, so let me move things a little bit. There was also a reduction in all-cause mortality as well. Serious adverse events significantly were higher in the intensive treatment arm. So they did have where we either controlled for blood pressure to less than 120 or conventionally to less than 140. So as expected, we had more side effects. But surprisingly, there was less orthostatic hypotension in the intensive arm, but more syncope complaints. So that study really, it had some issues with not covering all patients, but really led us to believe that we should probably be using lower blood pressure goals in these patients than the ones that we were currently doing. But there was a lot of disagreement on how low we should go with this. And that led to explosion of different guidelines that were all different. So you can see these are the guidelines that came out between 2014 and 2017. And some of the guidelines, and we'll focus basically on these patients that are equal or greater than 60 years old. So you can see that some of them, the guidelines said less than 140/90, some said less than 130/80. And then we had the 2017 guidelines that said everybody over the age of 60, that they really should have a blood pressure goal less than 150. So that was kind of basing it more on the HIVIT trial, but they included these patients that were younger as well. So there was lots of controversy about whether we should really be classifying our patients greater than 60 and not aggressively treating their blood pressure after we have this study that tells us that the patients will do better if we treat their blood pressure more aggressively. Thank goodness that we came up with a new set of hypertension guidelines in 2017. And this was really the goal of these guidelines was to get agreement. So to get everybody in agreement with how we should treat blood pressure for both our young and our old. So they came up with goal blood pressures for the general population should be less than 130/80 if they've had a cardiovascular disease event. So that would be a stroke, an MI, or peripheral vascular disease. Or if something called their ASCVD score, which we'll talk about in a minute, was their 10-year score, which is just a risk of them having a cardiovascular disease event, was greater than 10%. But for patients that had not had a cardiovascular disease event and their score, 10-year score was not greater than 10%, they would have a goal of 140/90. Now, they also did something that made so much sense to me. It made it very clear what we should do for our older patients. So first of all, they did make the comment that if patients that are over 79 years old, you don't have to calculate out that ASCVD score because just because of their age, they're going to have a score that's greater than 10%. And that so therefore the goal for that group in general is 130/80. But they added another part which says that patients with a high burden of comorbidities and limited life expectancy, higher goal based on the patient preference and clinical judgment could be used as well. So this was important because it really did help to spell out that, yes, we should be carving out for our patients that can't tolerate these blood pressure meds, that we could use a higher goal as well. So I did promise to you, I would tell you what the ASCVD risk estimate is, and I do have in there a link that you can click on that and it'll take you basically to a calculator to calculate the risk, but it's based on age, gender, race, blood pressure, the total cholesterol, high density lipoprotein, low density lipoprotein, diabetes, current hypertension treatment, whether they're on a statin or an aspirin already. So like I said, those are what we calculate for patients that are less than 80 years old, excuse me, over 79 years old. All right, so I just added the last column here, which is what we already talked about, but basically this helped to clear up some of the controversy that was out there about when should we start treating high blood pressures in our older patients. All right, so to answer this question, basically, I don't know if anybody wants to answer this, but we have an 81-year-old female. She has hypertension and osteoarthritis. She reports no falls in the last 3 months. She swims 5 days a week and walks 1 mile. What do you think her goal blood pressure would be? Anybody? I'll see if I haven't been checking the chat for the last few minutes. All right, I see a lot of people put in their A, and I agree with that. So she's a healthy 81-year-old. And when we have a healthy 81-year-old, we still will need to watch for side effects. But she would be somebody that I would want to give the benefit of having the lower blood pressure. So at least at this point that we would be shooting for the same value that we would shoot for a younger patient as well. So less than 130/80. All right. Sometimes it doesn't want to advance. There we go. So according to these guidelines, and I do want to point out that I don't think I made much of a point of that, but they did really get almost all the different organizations to really weigh in on these guidelines. And I think that's why We were having guidelines every year, but now we haven't had guidelines now for 6 years. All right, so this is also an 81-year-old female who has a history of hypertension, osteoarthritis, heart attack, stroke, and she also has heart failure with preserved ejection fraction. So she's fallen 3 times in the last month. She resides in an assisted living facility and requires help with her bathing. So what do you think her goal would be? Anybody have any idea? Okay, let's see, what time is it? So I'm not sure. So I'm seeing a lot of different values, but probably what I would have for her goal blood pressure, because she's fallen multiple times, and she has lots of comorbidities, that we would probably be okay with her less than 150/90. So she would be somebody that I would say would be a patient that we would have a discussion with, the fact of risk versus benefit. She may have different reasons that she's fallen and that we can fix. And if so, that might change over time. But I would normally say that I would shoot for 150/90 in somebody with this type of a history. All right, and I do apologize. I just has got a lot of waiting before I click after I click the button. So now we're going to talk a little bit about treatment and prevention of hypertension now that we know the goals. All right, so you probably have heard of all of this, but I did want to let you know there are studies that show that all of this does actually help. And we'll get a little bit specific about exactly what we mean by physical activity, because that has been studied and defined: weight control, smoking cessation, stress reduction, avoidance of excess alcohol, a heart-healthy diet, and behavioral therapy such as meditation and biofeedback. So I want to start with the heart-healthy diet, because I think there is all kinds of information out there about what we should be doing to protect our heart and prevent hypertension as far as our diet goes. This has been a subject that really has kind of exploded in the last 10 years, I would say. So I have the dietary approaches to stop hypertension, or the DASH diet. Those have the asterisks around it, because that's where the literature really does show that changing the diet to a DASH diet does help to decrease long-term outcomes. Now, some of these other things have also been studied and shown benefit, but the DASH diet has really been studied in a more randomized controlled pattern in multiple studies, and always is seeming to give about the same type of results. So that's where we have most of our evidence. So there's also information about limiting your carbohydrates and having more of a vegetarian or plant-based diet. The Mediterranean diet, lots of information out that is recommending that. There is a study that shows that it helps as well. That low sodium intake, like I said, that's kind of controversial, and probably because it's more important for our older patients than for our younger patients. Also maintaining magnesium and potassium, and limiting alcohol intake. So all of these are different things that have been studied to show what is actually a heart-healthy diet. DASH diet. So I meant to ask before I clicked to this what the DASH diet is, if anybody knew what it is. It's really fairly similar to what you probably have been familiar with, and very similar to the Mediterranean diet. So high in vegetables, fruits, and low-fat dairy items, high in whole grains, nuts, fish, and poultry, low in red meat, sweets, and sugar-sweetened drinks. So just in a nutshell, that is what in the studies have shown is a way to eat to basically prevent cardiovascular disease, including hypertension. All right, how about exercise? So this is another area where they have done quite a bit of studies about. So what really exercise would mean to prevent these cardiovascular disease outcomes, including hypertension, would be 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous aerobic activity per week. So you can split that up into 5 or 7 days a week to do your exercise to come up with that 150 minutes or 75 minutes. And in addition, at least 2 non-consecutive days per week where you do some muscle strengthening activities. And the guidelines actually are pretty specific about what these muscle strengthening activities would involve. And you can see what it says in there. Now, they also do recommend to involve fitness experts with older patients, and whether that is really a fitness trainer or a physical therapist, to make sure that our patients don't injure themselves as they start to do this exercise. All right, so that kind of concludes the section about non-pharmacological ways to prevent hypertension. I don't know if anybody has any questions about that before I move on to the next section. All right, so moving on, I'm going to talk about, oh, go ahead.
I'm trying to turn on my speaker.
Okay. Did you have a question, or you were just working with your speaker? Okay, we'll go on, and if anybody has questions, we'll have time for that at the end as well. So which of the following medications may aggravate hypertension? Anybody have some ideas of what you think might aggravate hypertension? Okay, so I'm seeing ibuprofen, I'm seeing acetaminophen, I'm seeing pseudoephedrine. All right, so on this list, the medications that would have some trouble with hypertension is, the first one is ibuprofen. So ibuprofen is available without a prescription. It's non-steroidal anti-inflammatory drug. Naproxen is also available without a prescription. But any of the non-steroidal anti-inflammatory drugs will increase blood pressure. They cause fluid retention. Acetaminophen it doesn't really affect blood pressure. So that is something we can use as an alternative to the ibuprofen if we need to treat pain in our patients, especially our older patients that are at risk for hypertension. Pseudoephedrine, so that is a common medication that's over the counter. The trade name on it is Sudafed. It's in a lot of the decongestants that are available without a prescription. But that does definitely increases your risk for hypertension as well. And then medications like the statins really don't affect blood pressure. So looking at those meds that cause problems, non-steroidal anti-inflammatories that we mentioned, alpha agonists are drugs like the decongestants. And then we also have the group of drugs called the serotonin norepinephrine reuptake inhibitors. So the 2 common medications in that class are duloxetine and venlafaxine. And these have been shown to increase blood pressure, not by a lot, usually by somewhere between around 5 millimeters of mercury for the systolic blood pressure. So it's important for us to at least be aware of this and watch when we start those medications. We're usually using those medications for depression, anxiety, or pain. All right, some other medications that we don't see as often, but can definitely contribute to hypertension is corticosteroids. More of a concern when patients are chronically taking these. The angiogenesis inhibitors or tyrosine kinase inhibitors. These are medications that are primarily used in cancer treatment. And amphetamines will certainly increase blood pressure as well. There are also some disease states that increase hypertension: sleep apnea, renal artery stenosis, primary aldosteronism. All of those can increase blood pressure as well. So if we have a patient that has sleep apnea, important, we think it's important for them to get treatment. There have been some studies that show, even though they get treatment, that it doesn't affect specifically the outcome of blood pressure as much as we originally thought, but it does help with other outcomes as well. So important to get treatment. All right, so now I'm going to talk a little bit about the preferred medication treatment of hypertension. And this is something that changes every here and there as they do more studies. But right now, what is recommended are thiazide diuretics. So those are medications like chlorthalidone and hydrochlorothiazide. And it's important to remember that you might need a potassium supplement added as well. Our next medication for preferred medication treatment is calcium channel blockers. Common example is amlodipine. We also need angiotensin. The other choice would be angiotensin converting enzyme inhibitors, commonly known as ACE inhibitors, or angiotensin receptor 2 blockers, which we commonly refer to as ARBs. And common examples are medications like lisinopril or losartan. So I did want to let you know that these preferred medications, the guidelines are very specific in the fact that if a patient has a reason, so for a different medication, such as a patient with congestive heart failure, where we use beta blockers that do have some antihypertensive effects at all, that the preferred may really change based on the other issues that the patient is having. Wanted to talk a little bit about some other considerations in our older patients for blood pressure control. One is, and this is something what is very common in our older patients, but does anybody know what it's called when the systolic blood pressures are high, but the diastolic blood pressures are low? See if we have any takers on this. All right, well, what that's called is isolated systolic hypertension. And one thing that we know about isolated systolic hypertension is that it's much more common in our older patients, and it's associated with negative cardiovascular outcomes. So it is something that we have to take into account when we're treating our older patients, that this idea of having a high systolic blood pressure might not, usually if either number is high, so when we say our goal is 130 or over 80, so if either the 130 or the 80 is high, we would treat it. But this is somewhat the exception because we don't want our diastolic pressures to go too low. They are related to cardiac perfusion. So if you lower the diastolic blood pressure, and generally what is considered normal is 60, but that is somewhat controversial. So sometimes it may be okay to go a little bit lower if the patient is tolerating it, but going too low will affect the perfusion of basically the cardiac, the vasculature. So we have to be very careful not to go too low. So in some cases, we might have somebody with a higher systolic blood pressure that we're not going to treat because their diastolic pressure is low. The best drugs to treat this, I just noticed I spelled amlodipine wrong, but dihydropyridine calcium channel blockers, so amlodipine, and diuretics such as chlorthalidone or hydrochlorothiazide, both which are first-line treatments for hypertension anyway, are really the best studied medications to treat this isolated systolic hypotension. Another area that we have to pay close attention to for our older patients is orthostasis. And as I told you previously, is those baroreceptors don't work as well in older patients, and those are really meant to keep homeostasis. So they try to keep your blood pressure the same, but they don't work. So a patient that may be on a medication that causes their blood pressure to drop when they stand up, they're not going to work as well, and we can get falls with that. So really, first thing we want to do is if there's any other medications that cause orthostasis that aren't blood pressure medications, and the common ones are dopamine agonists that are used in restless leg syndrome and Parkinson's disease, and tizanidine is a muscle relaxant that can cause that orthostasis. We would get rid of those first. But we would also think about changing these medications that are very high in causing orthostasis. So that would be short-acting nitrates, drugs like isosorbide or nitroglycerin paste, alpha blockers, which is prazosin, terazosin, or doxazosin, and then also clonidine, which is a common go-to medication when we cannot get the blood pressures controlled with the 3 drugs that are preferred. But that medication also can cause some problems with orthostasis. So other things to think about, because sometimes we run out of drugs that we can use. So really trying to think about, is there other things that are causing the orthostasis? Things like a fluid status, and are they drinking enough water throughout the day? Abrupt withdrawal of steroids will definitely cause some adrenal insufficiency, which is characterized by hypotension as well. And we really, as I said, we're going to really look at all those medications that cause orthostasis and think about the risk versus benefit as we start to try to peel them off so that the patient doesn't get dizzy and doesn't fall. I did want to just put in here the Beers list. Most of you probably are familiar with the fact that the Beers list is a list of medications that we should try to avoid in our older patients. And just to let you know that certainly the clonidine is on there, as well as the peripheral alpha-1 blockers, so the drugs like doxazosin, prazosin, and terazosin. This slide also, the other thing they have on the Beers list is nifedipine immediate release, but we all know that that is not a good drug to be using for blood pressure, and I haven't seen it used in many, many years, so hopefully you won't see it used either. All right, getting into the next section about monitoring for blood pressure. So first of all, I think about monitoring for the side effects, and all of these blood pressure medications do have some side effects that we have to watch for. And if they occur, think about either backing off the dose, adding other medications. So amlodipine, which is usually used, and its cousin felodipine, they both can cause peripheral edema. So watching for that's important when you start these medications. Diltiazem and verapamil, which are also calcium channel blockers, so also first line, but not used as much because they can cause that slow heart rate, and they can also cause constipation. And I really did gear this towards side effects that older patients commonly get. Our thiazide are diuretics in general, so the chlorothalidone and the hydrochlorothiazide are the thiazide ones that are first line, but also furosemide and spironolactone. Those all cause electrolyte disturbances. And for our older patients, they may feel like they need to rush to the restroom, so we need to ask about that, because that can also contribute to falls. The ACE inhibitors, such as lisinopril, is the most common one. We get the elevated potassium levels. You can get that chronic feeling to have to cough because of the effect it has on bradykinin. Losartan, valsartan, candesartan, all the ARBs, they can also elevate the potassium levels, but they don't cause the cough problem. Clonidine and guanfacin, guanfacin, I'm not saying that right because we hardly ever use it. Let's see where we, whoops. They can cause orthostasis, but also they can cause something that is very significant in our older patients, and that is they can cause confusion and depression as well. So important to watch for that. They definitely tend to be medications that will make patients more sleepy as well. So drowsiness is not uncommon when you first start those, and sometimes that can be prolonged. And then the terazosin, doxazosin, and the prazosin, all of those can cause the orthostasis as well. And certainly any blood pressure medication can cause orthostasis, but you can see some of those are more common to cause that issue. All right, so blood pressure monitoring. So we talked about the medication monitoring. So what about blood pressure monitoring? So home blood pressure monitoring is definitely appropriate. The guidelines come out and say that it is sometimes preferred because sometimes patients' blood pressure is higher when they're coming into the clinic. And I know I've seen this quite a bit, that just even the what a patient needs to do to move to get to the clinic will sometimes make their blood pressure higher when they first arrive. So making sure that you give them time to relax, and then also using those home blood pressure tools as well. One thing about the home blood pressure monitoring is we want to make sure the cuff is the right size. Otherwise, we do get inaccurate blood pressures. Avoid the use of the wrist blood pressure monitors. Those are not very accurate. They're easier for the patient to use, but they're not accurate, so not very helpful. And then it's not on the slide, but I always do recommend that we do calibrate. So we do the blood pressure in the clinic along with their home blood pressure cuff. So have them do that and just see if there's a lot of differences. We want to do those pretty close together because blood pressures do vary a lot throughout the day. And there are, I know the guidelines do suggest continuous blood pressure monitoring. I am not aware of a place that we can get that completely continuous blood pressure monitoring. Guidelines from what I've read, they put that in there because they think that would be the best, but that technology is not commonly available, although we do have lots of different places where we can get very frequent blood pressures. So something like Medtronic. And then I know that there are some of the smartphones basically can also do this blood pressure monitoring that is happening very frequently throughout the day. So all of those are helpful, but again, would want to compare it to what is being done actually, especially if it's a patient's own device. Medtronic is already calibrated, but what is being done in the clinic as well. All right, so that is basically just my quick overview of hypertension today in older adults.